In Chapter 3, we're going to look at drugs used for depression, bipolar disorders, and attention deficit hyperactivity disorder. When we think about depression, we have what's known as the amine hypothesis of depression. It basically says the reason why folks are depressed is because they have low levels of norepinephrine and serotonin. The origination of this theory is by the drug reserpine. Remember the mechanism for reserpine we discussed back in autonomics? This is a drug that can destroy storage vesicles and deplete neurotransmitters, including norepinephrine, serotonin, and even dopamine. The side effect of reserpine? Severe depression. So this drug helped us to form our theory of depression. And all of our antidepressants are going to work to increase the levels of norepinephrine, serotonin, or perhaps both. Depression joins a list that I give you at the bottom of this slide of diseases and neurotransmitters that are very, very popular on your Step 1 exam. For example, Alzheimer's. In the case of Alzheimer's, you have a decrease of acetylcholine neurons in Meinert's nucleus. Do you remember the type of drug that we like to use for Alzheimer's disease? It's acetylcholinesterase inhibitors, drugs like donepezil, which will increase the levels of acetylcholine. In Parkinson's disease, we have a decreased amount of dopamine and an increase, relatively speaking, in acetylcholine in the substantia nigra. So Parkinson's is a condition where we want to raise the levels of dopamine, block acetylcholine by blocking muscarinic receptors. In psychosis, you have increased levels of dopamine, perhaps also too much serotonin in the mesolimbic tract. The types of drugs we're going to use for schizophrenia block either dopamine receptors or serotonin receptors. And here we deal with depression. In depression, you have low levels of serotonin and/or norepinephrine, perhaps in the amygdala. Once again, we're dealing with changes in behavior, changes in mood, so we believe these transmitters are very important in the management of depression. When we look at drugs used in depression, the most popular drugs today as antidepressants are the selective serotonin reuptake inhibitors. SSRIs include the drugs fluoxetine, paroxetine, sertraline, citalopram. Now, if you can remember citalopram, you can remember a derivative of this drug called S-citalopram. Simply add the letters ES to the beginning of the drug's name, and you form a second very popular drug. And we also have the drug fluvoxamine. These are drugs that selectively block the reuptake of serotonin. They are our #1 drugs for depression treatment today. They're also useful for obsessive-compulsive disorder, for bulimia, for anxiety disorders. Remember, it's chronic anxiety because serotonin drugs are going to have a slow onset. Acutely, benzodiazepines are effective. We can use SSRIs for PMDD, premenstrual dysphoric disorder, and even for post-traumatic stress disorder. These are our favorite drugs for these various conditions. When we think about SSRIs and their advantages over older antidepressants like TCAs or MAOIs, first of all, they have an increased therapeutic index. They are just a safer group of drugs compared to our older antidepressants. Second, they don't have any autonomic side effects. Some of our older antidepressants can block muscarinic receptors and block alpha receptors, but SSRIs do not. These drugs are also non-sedating compared to the older antidepressants, and these are all of the advantages and why this group of drugs is so very popular. When we look at the side effects for SSRIs, we see a number of things, but make sure you highlight sexual dysfunction. The most common reason for patients to discontinue an SSRI is sexual dysfunction. Specifically, they're likely to complain of anorgasmia, an inability to have an orgasm, or decreased libido. So clearly sexual dysfunction can be a reason why some people would not want to continue taking these drugs. They may actually cause some initial weight loss. There's debate about whether that weight loss effect can continue, but compared to older antidepressants, many of which can actually cause weight gain, this is certainly a difference. We also have to be aware of possible serotonin syndrome if we take a second drug that can also increase the levels of serotonin. When it comes to drug interactions, we mentioned serotonin syndrome on the previous slide. This can happen with MAOIs, with TCAs, both of which are drugs that can increase the levels of serotonin, and it can even happen with the opioid meperidine. This is a drug we will discuss in detail in a later chapter in our CNS section, but meperidine forms a metabolite that can act like an SSRI, and that's why it can increase serotonin, and that's why it can cause serotonin syndrome. Many of our SSRIs inhibit P450 enzymes. Fluvoxamine and fluoxetine in particular are the most important drugs for this property. Important interactions between SSRIs can occur with benzodiazepines in the treatment of anxiety. The SSRI, as a P450 inhibitor, can increase the levels of the benzodiazepine. Citalopram is an example of an SSRI less likely to have a P450 effect, so it is safer overall when it comes to drug interactions. Next, we have our tricyclic antidepressants called TCAs. TCAs include amitriptyline, imipramine, and clomipramine. In fact, the ending ipramine is a common ending that we see for 2 out of these 3 drugs, and even for some others that are not mentioned on this slide. These are drugs that are nonspecific reuptake blockers for both serotonin and norepinephrine. Once again, think about the type of neurotransmitter that our antidepressants are affecting. TCAs affect both serotonin and norepinephrine to increase both of their levels. In terms of uses, when it comes to using TCAs for depression, anxiety, and OCD, their use in these conditions has been dramatically reduced. In fact, you're much more likely to use an SSRI as an antidepressant or for anxiety or OCD. What are some things that we still consider using a TCA for today? One of those things is neuropathic pain. You might imagine diabetics. Diabetics get neuropathies, or patients with postherpetic neuralgia, the pain of shingles. Options for treating this type of neuropathic pain would include TCAs, like amitriptyline, for example, gabapentin, and pregabalin, very popular drugs today for neuropathies. A second use for TCAs, enuresis. This is bedwetting. When you're dealing with a kid older than age 3 who's still wetting the bed, possibly you can use a TCA for this kid because of its anti-muscarinic effects. Blocking muscarinic receptors is going to decrease urination. When you think about the side effects of TCAs, they have a number of side effects, and some of it is related to their ability to block autonomic receptors. TCAs block both muscarinic and alpha-1 receptors. So when you describe the toxicity of a TCA as the 3 C's, coma, convulsions, and cardiotoxicity, certainly they can increase your risk of seizures, possibly cause coma, but let's focus on the cardiotoxic effect. In fact, I'm going to challenge you to come up with multiple ways that a TCA can be cardiotoxic. First of all, what is the mechanism of a TCA? It includes blocking the reuptake of norepinephrine. With more norepinephrine in the synapse, you can get a cardiotoxic effect, possibly causing arrhythmias. A second way is that TCAs block muscarinic receptors. Blocking muscarinic receptors, that's an atropine-like effect that will increase the heart rate. Third, TCAs block alpha-1 receptors. If you block alpha-1s, you're going to vasodilate. You get a decrease in blood pressure, and you should be able to predict what happens next. If the pressure goes down, you get a reflex tachycardia. So 3 ways in particular that TCAs might increase the heart rate and possibly cause arrhythmias: blocking the reuptake of norepinephrine, muscarinic block, alpha-1 block leading to reflex tachycardia. TCAs may also cause the arrhythmia known as torsade. Torsade de pointe is a type of ventricular tachycardia, also can be caused by this group of drugs. Just because they can, TCAs also block histamine H1 receptors, and this is why this group has a very sedating effect. There are a number of drug interactions with TCAs. You can get a hypertensive crisis with MAOIs. That's because those are two drugs that can both increase the levels of norepinephrine. You can get serotonin syndrome if you combine a TCA with an SSRI, an MAOI, or meperidine as previously discussed. Our oldest group of antidepressants are the monoamine oxidase inhibitors. This group includes the drugs phenelzine and tranylcypromine. These are non-selective inhibitors, meaning they inhibit both MAOA and MAOB. They can be used in atypical depression. Most commonly today, you see these as a very, very reserved group of drugs for patients who have not responded to drugs like SSRIs. When it comes to MAOIs, there are a number of drug interactions to be aware of. In fact, this group of drugs can interact with a long list of other drugs out there, including we can increase the levels of norepinephrine leading to a hypertensive crisis. Since MAOIs are going to block the metabolism of norepinephrine, we have to watch out for any other drug that might also increase norepinephrine levels, including watch out for tyramine. We've discussed tyramine earlier, found in red wine and cheese in particular. Tyramine, in the presence of an MAOI, is going to act like an amphetamine, causing the release of norepinephrine. But you can imagine a number of other drugs that also increase norepinephrine levels, like TCAs. Alpha-1 agonists, because of their ability to vasoconstrict, that can also increase your blood pressure. Even other drugs like levodopa that might turn into dopamine, for example, we can have a number of interactions that could result in a hypertensive crisis. But most importantly, watch out for the tyramine effect. We have to also be aware of increasing serotonin levels leading to serotonin syndrome. This happens if you have an MAOI combined with an SSRI, a TCA, or once again we see meperidine. Signs and symptoms of serotonin syndrome: muscle rigidity and hyperthermia in particular are symptoms that you want to note. We can also see sweating. We can see autonomic instability and possibly seizures as well. Let's look at some other antidepressants. First, we have the drug trazodone. Trazodone is a drug that works through serotonin pathways as an antidepressant, but it has side effects that include cardiac arrhythmias and possibly priapism. In fact, if you focus on the ability of this drug to cause priapism, in worst case scenario, you can get a long-lasting, very painful erection, and that is actually one of the rare but still outstanding side effects of this drug. We have venlafaxine. Venlafaxine falls into a category of drugs that we often refer to as SNRIs, a serotonin norepinephrine reuptake inhibitor. But SNRI as a category has really already been invented, hasn't it? I mean, how do TCAs work after all? Tricyclic antidepressants block the reuptake of serotonin and norepinephrine. Make the connection that venlafaxine works just like a TCA. But earlier we discussed a lot of side effects for TCAs. What makes venlafaxine so popular today? Well, it has the beneficial mechanism that the TCAs have without the autonomic side effects. In other words, venlafaxine does not block muscarinic receptors, nor does it block alpha-1 receptors. It is a very, very popular alternative to SSRIs for the treatment of depression. We can also see this drug used for fibromyalgia, as well as we can consider TCAs, though those would be a backup drug given their side effects profile. Our third drug is bupropion, a drug that's a dopamine reuptake blocker, but also probably is blocking the reuptake of norepinephrine as well. Remember, the theory of depression involves serotonin and norepinephrine. There's really a minimal to no role for dopamine. So perhaps the benefit of this drug in depression is its ability to block the reuptake of norepinephrine. Besides being used as an antidepressant, bupropion can also be used in smoking cessation. When I think about this drug, The most popular step 1 question related to bupropion is this: since this drug does not cause sexual dysfunction as a side effect, it is the most popular drug to switch the patient to after they've been on an SSRI but complained of sexual side effects and they did not want to continue on that medication. So switch them to bupropion because it doesn't cause sexual side effects. While on this medication, there is a low risk of seizures while taking bupropion, so be aware of that. Our final drug is mirtazapine. No other antidepressant works like mirtazapine. It's an alpha-2 antagonist. If you think about that mechanism, we had actually reviewed this earlier in autonomics, where we discussed that if you inhibit an inhibitory receptor, the pathway becomes stimulatory. Remember that alpha-2 receptors are presynaptic. They're GI coupled. They decrease neurotransmitter release when stimulated. Therefore, when I block an alpha-2, the nerve will continue to release norepinephrine. That's its mechanism as an antidepressant. This drug is associated with weight gain, and it has been used in patients who can use an increase in their weight. In the margin is a note on varenicline. This is a drug that's a nicotinic receptor partial agonist, used in smoking cessation. While on this medication, we encourage patients to continue to smoke, but when we take varenicline, it's going to compete with the action of nicotine at those nicotinic receptors, thereby blocking the reinforcing effects of the nicotine. Over time, what we hope is the patient will have a reduced craving for the nicotine, and slowly they can begin to taper off their use of cigarettes. To summarize the treatment of depression, the neurotransmitters involved are norepinephrine and serotonin. In each case, those transmitters are too low, so our antidepressant drugs are designed to increase the levels of one or both of those neurotransmitters. Next, we will look at lithium and its use in bipolar disorder. Lithium remains the drug of choice for bipolar. It's a very, very popular drug for this condition. It manages the symptoms of bipolar very, very effectively. You should know the mechanism for lithium. It prevents the recycling of inositol by blocking the enzyme inositol monophosphatase. In fact, I've drawn a cartoon to illustrate this. In the recycling of inositol, the very last step involves the conversion of inositol monophosphate into inositol. That's where the enzyme inositol monophosphatase works. Well, lithium blocks that enzyme. Thereby, you're not able to effectively recycle inositol. If you think about which type of G protein pathway will be most likely affected by this action, who uses IP3? Well, that would be your GQ coupled receptors. There are a number of side effects for lithium we need to be aware of. Even though it is the smallest drug that we have by molecular weight, it has a narrow therapeutic index. Lithium is dangerous. It can cause a skeletal muscle tremor that kind of reminds you of essential tremor. You also have to be aware of hypothyroidism with goiter. Possible hypothyroidism with goiter because lithium can decrease TSH effects and perhaps also affect 5'-deiodinase, the enzyme that converts T4 to T3. A more common side effect of lithium is nephrogenic diabetes insipidus. A large percentage of patients, as much as 1/3 of patients, may actually experience this side effect. The reason why lithium causes nephrogenic DI was actually reviewed earlier in our cardiovascular lectures, where we were discussing exactly how lithium can damage V2 receptors in the collecting duct. Do you remember that lithium can enter those principal cells of the collecting duct by entering through sodium channels? So what's the drug that we use to treat nephrogenic diabetes insipidus caused by lithium? We use the sodium channel blocker amiloride to prevent lithium entry. Lithium is teratogenic. It can harm the fetus, causing Ebstein's anomaly, which is a malformed tricuspid valve. This is on a short list of drugs that we know the teratogenic effects that they may cause, and therefore it's a very popular step 1 question. We have alternatives to lithium for bipolar disorder. Valproic acid is a very popular alternative. Carbamazepine, also used as an anticonvulsant, can be used in bipolar, and even our atypical antipsychotics can be used in this condition. We end this chapter by looking at drugs used in ADHD. Methylphenidate has been our most popular drug. Methylphenidate is an amphetamine. It's going to cause the release of norepinephrine. The benefit of increasing the levels of norepinephrine is really unclear in this condition. You see the box at the bottom reminding us of that fact. But amphetamines are preferred, and methylphenidate, again, one of our most popular choices. The side effects for methylphenidate and other amphetamines include agitation, restlessness, insomnia, and cardiovascular toxicity. All of those are consistent with increasing the levels of norepinephrine. The backup drug here is atomoxetine. It's a selective norepinephrine reuptake inhibitor. The drug is going to work similar to cocaine or TCAs to increase the levels of norepinephrine in the synapse. And this drug is considered a backup to amphetamines.